Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Hi, everybody, and thanks for tuning in for Direct Connection. It is Addiction and Recovery Week here on MPT, and Saturday at 7, we will premiere, along with dozens of local TV and radio stations, a program called Breaking Heroin's Grip, Road to Recovery. Here's a preview.
Rock bottom changed every time. Like rock bottom when my father wouldn't talk to me, when I got in trouble, when I got on probation, when I lost my girlfriend, when every rock bottom that I thought I had was not there. There was no rock bottom for me. I'm now sitting in jail scheming of how I'm going to get out of this one. I was sitting there, and November 21st was when I woke up, locked up without a drug or drink inside of me.
Joining us now in the studio is Dr. Ingvild Olsen, Medical Director of the Institutes for Behavior Resources. Dr. Olsen, thanks for stopping by.
Sure, thanks for having me.
Tell me about the people you treat for addiction.
So I primarily see people who have an opioid addiction, so heroin, prescription opioids, but about 70% of the individuals that I see also then have other substance use disorders, so cocaine, alcohol, benzodiazepines, and other related medical and psychiatric conditions.
So this problem, opioid addiction, over the last 15 years or so has exploded nationally. The number of people who overdose has quadrupled, I've read. Mm-hmm. From your perspective, what's changed?
So I think that, this isn't necessarily a new phenomenon. We have had heroin, particularly in Baltimore City, for a long time. I think what's really changed in the past, particularly in the past couple of years, is the addition of fentanyl. People talk about the prescription opioid epidemic that started about 20 years ago or so, and that significantly led to the increase in opioid overdose deaths and problems related to opioid overdoses. But in the past couple of years, it really has been fentanyl that has dramatically changed the landscape.
And fentanyl, for people watching, is a legitimate pharmaceutical that has become a street drug.
So it's interesting. So you're right. The fentanyl is a pharmaceutically made medication that is used for severe pain, particularly for people who have cancer pain or sickle cell disease. The fentanyl that's now out on the street and that is really causing the tremendous increase in overdose deaths that we're seeing not just in Baltimore and across Maryland, but also nationally, is illicitly made fentanyl. So kind of like the methamphetamine labs of the past, there are now fentanyl labs where kind of rogue chemists have identified and figured out how to make these fentanyl analogs, so different kind of changing a little chemical structure here and there so that they are hard to detect, and they're unbelievably potent, 50 times more potent even than heroin. And
then there's something even more potent than fentanyl, which is carfentanil?
Correct. And so carfentanil is, again, one of these analogs of fentanyl. And carfentanil really has been used in veterinary medicine as elephant tranquilizers. But again, these chemical structures, you tweak one little piece here and there, and you can increase the potency tremendously.
What is the route into addiction for most of the people you see? Was there a progression through the old gateway drugs? It was marijuana and then something else leading to heroin? Or increasingly, you hear about people who are prescribed opiates for pain management, and Percocets or something like that leads to addiction.
Right. So what we certainly have seen, and there's some good data out there, that before the year 2000, really 4 out of 5 heroin users in particular really started just with heroin. After 2000, about 4 out of 5 new heroin users actually started with a prescription opioid. Now, where I work, we see a mix. So we have certainly people who have started kind of using heroin, have been using heroin for a long time, and now with fentanyl, they are extremely concerned about their own safety, and so that kind of helps propel them into treatment. We have some people who started with prescription opioids and then progressed to heroin. I think the challenge is, really making sure that people understand that there are effective treatments out there and there's hope and people can and do recover from this disease.
Let me remind our viewers, if you have a question about addiction and addiction counseling and treatment, give us a call. We'll have the number up on the screen. You can also tweet your questions. Our Twitter address is @MPT News. So the treatment angle has a reputation, frankly, of not always being all that effective. High relapse rate. What do you see?
So where I work, we provide a comprehensive set of services. So that includes counseling, individual and group counseling. We have what's called an intensive outpatient program where people come 4 days out of the week for several hours at a time. We also provide medications. So medications for opiate use disorder, there are 3 that we have that are FDA approved, methadone being one and the oldest, buprenorphine, and then injectable naltrexone being the newest. So we offer all 3 of those medicines. We also offer some primary care light services. We have a health home. So we are very recovery focused and really want to help take care of the whole person. And not every treatment is going to work for every one person, but in my experience, really when you can get people into kind of long-term care, that's when people have the best chance at recovery.
And how often can you get somebody into long-term care where this tsunami of demand has appeared?
Yeah, so we try and really have open doors. So when people walk into our doors, we try and get them into care as quickly as possible. There are also now outreach efforts going on across the city and across the state. If people are interested in or they have a question about themselves or their loved ones, in Baltimore City, they can actually call a crisis information hotline, and that number is 410-433-5175.
And I'll ask you to do that again at the end of the segment. Let's grab a phone call. Carroll County, this is Cindy. Cindy, thank you for the call. Go ahead.
Thank you for taking my call. I have a question. A family member of mine has had a similar pain problem for decades, and the doctors had put my family member on the morphine and then the sleep anxiety, the benzodiazepines and whatnot. And so my question is kind of like your approach of detox, and with people that are having severe pain, how do you treat the pain and what relief can you give? Because the reason why this person is in the pain clinic is because they have unresolved pain and severe pain of the spine.
Cindy, glad you called. Thank you very much. Doctor, what do you say?
No, so that's an excellent question, and thank you for that call, Cindy. So, part of what we have seen over the past 20 years is that, patients who have severe pain, and particularly what's called non-cancer pain, that, 20 years ago, we were all, as physicians, we were told, opioids, they have there's nothing to worry about. Start prescribing them kind of, for lots of different reasons. Well, what we do know is that the majority of individuals who are prescribed opioids for their chronic pain actually will have no problems with it. They will do fine. People do need to understand that anyone who takes an opioid at a high enough dose for a long enough period of time will develop what's called physiological dependence. And what that means is that if they stop taking the dose abruptly or dramatically cut down on the dose very quickly, they will go through withdrawal. But that actually is not the addiction. The addiction is
craving is something
craving
different.
is a very compulsive need to do anything and everything, and people will try and cut down and they can't. They will give up lots of responsibilities, both socially and at work, and give up their friends. They will do anything. Their life around getting and using that drug.
Is it the sort of thing where if you have 10 people and they all have back surgery and they're all given some opioid pain medication, that some group, 2, 3, 4 of them, are likely to have a problem because of some genetic predisposition or something else that's going on, and the others, no matter how much you gave them, wouldn't develop that craving part of the problem?
Right. So this is where, there's some debate about exactly how we define the problem. So I think you're right. So the genetic risk of, or the genetic component of developing an opiate use disorder or a substance use disorder is about 40 to 60%. So not everybody will develop the addiction. Every one of those individuals will develop physiological dependence, but not this unbelievable, strong craving that can't let them do anything else or think about anything else. The challenge is that even people who have physiological dependence and particularly have chronic pain, many of the same features of or accompanying conditions like depression and histories of trauma, and they also are risk factors for chronic pain, and they can complicate the chronic pain. So there now is actually a thought that really the same types of behavioral interventions that we use for addiction can also help in people with chronic pain, because it's really having to learn how to live with this chronic disease.
Interesting.
And I think for family members like Cindy and for others who are in that situation where they have chronic pain, the other thing they really need to ask their doctor is, what are the potential side effects? What are the risks? How do I protect myself from overdose? Because people can overdose even when they don't have the addiction.
Let's take a call from Montgomery County. This is Judith. Thank you for calling. Go ahead.
Hi, thank you for taking my call. I do live in Montgomery County. We have a terrific addiction problem. And what I've been aware of, and family members of other people that I know of, their loved ones go into rehab, cost $30,000, $40,000, $50,000 a month. They then leave. They go to recovery houses where there may or may not be drugs. Anyway, the cycle keeps going, and the cost out is incredible. And one thing that I have not heard of, maybe there is such a thing in Maryland and in Montgomery County specifically, is what's called evidence-based practices, where programs are assessed on certain criteria in terms of how they provide their services, the quality of service, the long-term success of the services. And I don't believe, and I could be wrong, so correct me, that there are any programs in Maryland that are connected to evidence-based practices, which
Judith,
I think
thank you for the phone
help
call.
us control.
Let me get you an answer here. Thank you very much.
That's a great question. And one of the things that we do have good evidence for is treatment that includes a medication. For opiate use disorder in particular. Now, it is also true that there is a spectrum of quality of care, as there is in any other medical entity or any other medical care practice. Maryland actually is now moving towards what's called accreditation of every level of care, every type of care, including residential treatment services. Last year, there was a bill that actually required a certification process for recovery residences. So I think that the question is right on, that we really want to make sure that we can actually, all of us as providers, provide the best quality of care to the people who walk through our doors, and that care is with best practices and according to what the evidence and science tells us.
Before we go, give me the phone number again. And certainly if somebody has a crisis, you call 911, but beyond that, where do you turn?
Yep. So the Crisis and Information Referral Line in Baltimore City is 410-433-5175.
Very good. Dr. Ingvild Olsen, Medical Director of the Institutes for Behavior Resources. Doctor, thank you very much.
Great, thank you.
And again, let me remind folks to tune in Saturday night, 7 o'clock for Breaking Heroin's Grip, Road to Recovery. A toll-free addiction hotline will be available throughout the simulcast and afterwards as well. Coming up tonight, understanding cardiovascular disease. We'll be right back.
This is a box that showed you a world beyond your own. It was just a box, but the world has changed, and so have we. And now the box can be almost any size or shape. And you decide what you want to explore. Anytime, any place. Break out of the box with PBS.
My child who's watching Super Y, and it said, what letter makes the sound R? And my 2-year-old is jumping up and down going, R, R, R. I love that. I wish I knew the genius that came up with Dinosaur Train. I mean, what little boy especially doesn't like dinosaurs and trains and to put them together in one show? My family does without a lot of stuff, but I would be horrified if we had to do without PBS.
Please support MPT.
Sometimes
the tears,
I get a good feeling, yeah.
Wanting to die. Nobody tells you
I believe
that without it,
I really do believe that
life can be appallingly boring.
Something's got a hold on me here.
You're making a mistake.
Am I? This is really very promising.
Something's got a hold on me right.
I don't think this is such a good idea.
You've been talking to my mother.
I am about to commit murder.
She always had a bit of a dark side.
Trying to scare me now. Let him give you a story.
He's in love.
I really wasn't. Stay away from my wife.
You got any idea the pressure I am now under?
And joining us for this week's Your Health segment is Dr. Mukta Srivastava, cardiologist with the University of Maryland Medical Center and assistant professor at the University of Maryland School of Medicine. Doctor, thank you for being with us.
Thank you so much for having me.
February is American Heart Month. We know that hundreds of thousands of people die every year of heart disease, but the thing is, so much of that is potentially preventable. How do you see it?
That's a great point for discussion. There are a number of lifestyle and pharmacological therapies that have been very effective at reducing the rate of heart disease in the United States steadily over the last decade, but it remains the #1 cause of death in both men and women. And I think the progress has really been made in public awareness of getting to a hospital in the setting of a heart attack. But some of the additional therapies, lifestyle changes in particular, aren't as prevalent. So a good diet, exercise, sleep hygiene, smoking cessation, these are all targeted lifestyle changes that can potentially reduce the incidence of heart disease. And secondarily, finding out if you're someone who should be on lipid-lowering medication, which has also been very effective in lowering heart rate, heart attack rates, and stroke rate.
And in the setting of symptoms of a heart attack, if somebody does get themselves to a hospital, it would be to see someone like you, an interventional cardiologist. Talk a little about the importance of getting to an interventional cardiologist and a cath lab as soon as possible.
Sure. The heart muscle is unique in that when there is damage to the heart, it rarely will regenerate itself. Other parts of the heart muscle may compensate and return the function of the heart close to back to normal. So in the setting of a heart attack, seeking medical therapy is critical in a very time-sensitive fashion. And from the time a heart attack starts to when the area of the heart muscle that's being fed by an artery that is blocked, It can be as short as 9 to 12 hours for that entire heart muscle to be infarcted, which means it's basically scar tissue. So in that setting, recognizing the signs and symptoms, taking aspirin at home and calling 911 or as soon as possible allows for the most efficient care for that patient.
And you have a particular interest in women and heart disease. Is there a difference in terms of recognition of symptoms? Do the symptoms differ to some degree between men and women that maybe would slow down the process of getting treatment for a woman having a heart attack?
There is a lot of talk of women and men presenting differently in the setting of a heart attack. The most classic presentation is a squeezing, tight pain in the center of the chest, a feeling like there's an elephant in the chest. And in reality, during an acute heart attack, both men and women very frequently will present with that same symptom, but women are less likely to attribute that to a heart attack and to seek medical attention. There have been studies that look at this, and the average delay for men to seek attention is 16 hours from onset of symptoms. 16
hours?
16 hours, compared with women, 54 hours, so almost 2 days that they will have symptoms.
Good grief.
That is a striking statistic, and there's a spectrum of heart attacks. So, for the most severe heart attacks, hopefully both genders present sooner than that. But
do you think there's a fear of overreacting, not wanting to be the person in the emergency room who thinks they have a heart attack but winds up having indigestion? And
yeah, I think that absolutely is a factor in delaying seeking care. And anecdotally, oftentimes the men we see present because they mention specifically that their wife forced them to seek medical attention, and so even on their end, there's this fear of overreacting.
Right. So the lesson is, don't be afraid to force somebody to seek medical attention. Let me quickly remind our viewers, just have a couple of minutes, but if you have a question, please give us a call. We'll have the number up on the screen. And the other thing we wanted to touch on was the difference between people hear heart attack, they hear cardiac arrest, and think that they're the same thing. And generally, hopefully, they're not always the same thing.
Absolutely. They're quite different. Cardiac arrest is essentially where the heart actually stops beating. The heart is a muscle. Every second, it contracts and pumps blood throughout the body. And cardiac arrest is when that process stops. And that is life-threatening within minutes. A heart attack is a situation where an artery that feeds the heart muscle is blocked. And so the heart muscle isn't getting enough blood flow. And potentially, if enough of the heart isn't getting enough blood flow for a prolonged period of time, then you may have cardiac arrest as a result of a heart attack. But you can also have a cardiac arrest from many different conditions. Sepsis, infections, drowning, overdose are all other causes of cardiac arrest.
A friend of mine, in the absence of any symptoms of heart disease, had a calcium score done. Family history of heart disease, no symptoms. What do you think of that technology, which is relatively new?
There's a lot of thought about how best to utilize this technology. In the general setting, if you don't have symptoms of heart disease, but you have a very strong family history and you want to target the therapy for a patient to minimize their future risk, a calcium score is very helpful in determining if there is any calcium in their arteries. And in that scenario, if there are no symptoms, you may then place that patient on a lipid-lowering agent, like a cholesterol pill, and you may be more targeted about their lifestyle changes, more specific about smoking cessation counseling, and also about watching for signs of heart disease.
So you would like to be less busy in the cath lab taking care of heart attack patients. Where do people start in terms of diet, exercise, blood pressure, diabetes, and so forth?
Well, I think a very good start is just recognizing your own personal risk. there is a tool that physicians used called the Framingham Cardiovascular Risk Calculator, and basically that inputs a few variables, your age, gender, your history of diabetes, smoking, hypertension, and gives you a 10-year risk profile of having a cardiovascular event. And so if you know you're in a higher risk category, you may be more aggressive in terms of pharmacological therapy and not just lifestyle changes. You would otherwise probably try to focus on all of these in moderation. Many times patients come to me and ask if they should cut everything out of their diet, and I think that's just not sustainable. So I usually say, eat everything in moderation, have a diet that's 80% high in vegetables, fruit, fiber, and minimize sugar.
I just have a minute. Let me see if I can get a very quick phone call from Nancy in Montgomery County. Nancy, what's your question?
I just wondered, is it possible for a woman to feel the symptoms of a heart attack, yet not seek medical attention and go on with their normal life?
Thank you very much. Have a minor one and never know about it.
That's a great question. And I think it certainly happens that women experience a silent MI, and because their symptoms are atypical, sometimes they may recall having a period of a few days where they felt profound fatigue, felt flu-like symptoms, and if the area of the heart that was at that their heart attack was in was not a large area, they may carry on.
Dr.
And not have
Srivastava,
noticed.
I apologize, but we're out of time. Thank you for joining us. Appreciate it. Thank you for joining us for Direct Connection, and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.